programs for these groups for health systems and payers to group themselves together to provide more efficient care for them. One of these groups is in the northern area of Ohio, and it's Mercy Health System, and they're a member of Catholic Health Partners. And so they're part of the Ohio demonstration for the Toledo area to provide a proposal for caring for dual eligibles in that area. We had the option to choose between using Buckeye, who is a payer up there, and also Aetna. There were 2 payers established for that area, and we had to review the payers and decide which one we wanted to use. And then we made the proposal on what type of care model we thought that they should use.
So we're here today to submit our proposal for a care coordination model through an exclusive partnership with Buckeye Community Health Plan. Buckeye is a Medicaid plan already operating in the Toledo area. Aetna has no Medicaid awards currently in Ohio to date, and in fact in August had its suit against Ohio dismissed in a failed attempt to challenge the awarding of the Medicaid contracts. With the April enrollment date coming up for dual eligibles that will be involved in this program, Mercy must have a model that's ready to deliver care today. And with the next ACO program application cycle slated to begin in spring of 2013, there isn't time to consider that model. So the model that we're proposing is one of patient-centeredness. So we want to talk just a little bit to you about what can happen with these dual eligible patients. And we thought we could best do that by giving you an example of a patient. The name has been changed to protect the innocent and comply with HIPAA. But we had a patient with a history of stroke, was being cared for in her home through some weekly physical therapy, had an event during the evening at her home, suffered a fall, went into the emergency room by ambulance, was admitted into an inpatient hospital stay with a stroke diagnosis. It was her 3rd stroke. After spending some time in the inpatient, they discharged her to a skilled nursing facility. At the skilled nursing facility, she was receiving physical therapy. However, a couple weeks into her stay at the skilled nursing facility, she had another episode in the evening. Ambulance came, took her back to the emergency room. She was diagnosed with blood clots in her lung and in her leg. As part of the treatment regimen for those blood clots, they put her on Coumadin, a blood thinner. Sent her back to the SNF and said, we need to get you to take her blood so that we can monitor her PTINR levels with this blood thinner. Sent her back. She did her 5 to 10 days worth of regimen on the Coumadin, but nobody told them to stop taking those blood samples. So for the rest of the time she was there, 100-day total stay in the SNF, she was having blood draws every day. And she wasn't having physical therapy. Okay. So her Medicare days expired. If you're familiar, Medicare gives you 100 days in that skilled nursing facility. She expired, but the facility that she was at was a Medicare only. They didn't accept Medicaid. So she was transferred yet again into a Medicaid nursing facility where the first night she became confused and disoriented and in fact tore down the blinds in her room trying to get herself up out of bed. Okay. So this is the patient experience that can happen with the fragmented care module for these dual eligibles. What we want to do is let Mercy take the opportunity to redefine health care for Margaret and other dual eligibles in Ohio and nationwide. Currently, spending on dual eligibles accounts for 1.9% of gross domestic product. That's just for dual eligibles. The spending and fragmentation of care for these patients has got to stop. We've got to find a better way. In our model, everything revolves around the patient. When the patient enters the Mercy Health System at any point, through a physician office, through the hospital, our EMR notifies the patient's medical home of the visit. If the patient receives care at a non-Mercy facility, our partnership with Buckeye will allow Buckeye to notify the medical home that the patient is receiving care in another facility. The medical home team is always involved with the patient. We will utilize 2 different innovations to provide this patient-centered care. The first is the virtual discharge nurse, and this is going to be implemented in our hospitals. Patients actually report better understanding with this virtual patient discharge nurse. And as we were thinking through the reasons and questions have come as they piloted this program, the patients tend to be more comfortable asking the nurse to repeat herself multiple times while they understand the instructions than they actually were asking a live person. They felt a little embarrassed asking a live person to repeat themselves, and so they actually garnered better understanding with this program. So we're going to give you just a quick demonstration of what the virtual discharge nurse looks like.
Elizabeth is a virtual nurse created by researchers at Northeastern University. She helps take patients through the discharge process as they leave the hospital.
Good afternoon. My name is Elizabeth and I am here to help you with the discharge process here at Boston Medical Center. You're John, is that right? It is great to meet you, John. As you might have noticed, hospitals are very busy places. My job is to make sure that before you leave, you feel that you have been given all the information you need to help make the transition from here to your home as smooth as possible.
Surprisingly, many patients reported that they preferred talking to Elizabeth over an actual nurse or doctor because they didn't feel rushed or talked down to.
So, are you a Red Sox fan?
The pilot was in Boston. We're sorry, any of you Yankees fans out there. The other model that we intend to develop and utilize is the care transition model. And this program was developed at the University of Colorado School of Medicine, and it starts really with the introduction of the wellness or a care coach. This care coach will be assigned to the patient when they initially sign up with Buckeye to receive their insurance through Buckeye. And the relationship really begins at that point as well. The care coach is going to have conversations with the patient even before the patient is in need of medical care. They can go over to their home and do a home visit. One of the things that we see with this particular dual eligible population is they're elderly and they're disabled in a lot of cases. And so there can be things in their home that actually are dangerous for them. So the care coach can go over, take a look, see if they have rugs that need to be tacked down, removed so that they don't have fall hazards. They can determine if they need handlebars installed and get them to the right social services to help get those handlebars installed. The coach will follow up every time the patient has an interaction with any piece of the medical process. They come in for a yearly exam at the office. That care coordinator is going to be calling them after the fact, following up with them. Did you understand what the physician said to you? Did you understand the changes he's made to your medication? If they go into the hospital, that care coach is going to be there at some point during their stay, helping to make sure that they understand what's going on and what they need, and helping them communicate with their other care providers. When they're discharged, in the example of Margaret Jones, she was discharged to the skilled nursing facility and then to a nursing facility. That care coordinator is going to be over there, not just helping the patient make sure they understand what all they should be doing, but visiting with the charge nurse at the skilled nursing facility, visiting with the caregivers that are actually going to be providing the care, so that they are more aware of the needs of that individual patient. The specifics of how this plan will work, I'm going to turn over to Rob and let him speak a little bit more.
So Alethea just gave you the background and the structure, but how are we going to operationalize this if we're truly going to move the needle and strive to improve quality, increase access, and reduce cost? How are we actually going to accomplish that? Well, it starts with the patient. We're going to empower and educate the patient so that they can take ownership in managing their own care. The 4 items here are resources that will immediately become available to the patients upon entry into our program. Access outside normal clinic hours via our website, frequently asked questions, web chats, and through the Buckeye Community Health Plan, an instrument called NurseWise. This is NurseWise. This is a 24-hour line available to all of our population. Our goal is to treat the patient in the lowest cost setting possible. So if a patient has symptoms such as elevated temperature, nausea, rather than them present in an emergency room or even an urgent care center, let's see if we can treat them first at home. Let's empower them with the ability to call this nurse line, receive feedback such as maybe hydrate, Tylenol, whatever the case may be, and in 20 minutes reassess. So that's point one. Point two, again, we're encouraging the self-management of this patient's condition. Our new electronic health record, EPIC, has within it something called MyChart. MyChart is a patient portal that allows that patient to look at their record and take ownership in their day-to-day chronic illnesses. Cranes is something you may be familiar with. It's an education platform. If there's something, a new onset disease or problem you're not very knowledgeable about, this is a free resource available on the website that you can use to educate yourself on how to better take care of your condition. And remembering that this is a dual eligible population and the Medicaid component means they're probably indigent. Resources such as money, transportation is a factor. Our health plan will provide 15 round-trip visits to and from selected health services. And in the event that they run out of those 15 round-trip visits, that's where this comes in, telemedicine. There are two things in front of you. One is a telemedicine station that will be used in our patient-centered medical homes. That's this device right here. So our clinicians will be able to link up with the patients in their home. Again, remember, we want to treat them in the lowest cost setting possible. The other device right here is the mobile unit. That mobile unit will be used when the nurse and the health coach, who's also a licensed social worker, makes those home visits. An Xbox Connect, you may think is a little odd sitting over there, but the Xbox Connect is actually something that was one of the reasons why we chose Buckeye Community Health Plan over Aetna. This is a provision that Buckeye is willing to provide to the family free of charge, along with the cost of setting up a high-speed internet connection. This is how we get into each of their homes at the lowest cost possible, and this is how we further entice engagement from the patient. So, you're aware now these are dual eligible populations, and as such, the Medicare component of their dual eligibility provides freedom of choice. So here we are, we're making this wonderful new care model, and they can get up and leave our newly created continuum of care at any point. How do we keep them in our continuum? Well, legally we cannot incentivize ourselves, but the health plan can. The health plan can provide provisions to the patient directly, incentives, if they meet these highlighted items, coming in for a flu shot, coming into their well check, coming into their standard exam, they can receive monies. Our health plan will provide them a prepaid cent account card. That card's reloadable. Each time that they actually manage their care by going to their already prescribed planned visits, they will receive monies on this card. Now keep in mind, this is a population that probably receives somewhere in the neighborhood of $600 a month. So these monies, while added up, come to $175, that could mean the world to someone that has $600 a month of planned money to use. We have a three-tiered approach towards trying to keep information in-house so that it's available to the clinicians that need it. The first approach is, of course, that they present to the provider, him or herself. It'll be captured immediately. Now, the second tier is Buckeye Community Health Plan. Their network reaches far beyond ours. If a patient presents to any facility accepting Buckeye Community Health Plan, their data will be captured there and disseminated to the appropriate clinicians. And the last catch-all, the last safety net, is CliniSync. CliniSync is a statewide information exchange. If they travel to any facility within the state using CliniSync, their information will be captured. Again, the idea is to control costs, be aware of what this patient is doing so that we can manage their care, keep it at the lowest cost possible. This will be our staffing model. Our medical homes are very similar to existing physician clinics. The difference is putting the patient first, making them the center of the care. So of course it'll be led by the primary care physician. We will also have a physician extender, either a nurse practitioner or a physician assistant. The registered nurse and a wellness coach, who is a licensed social worker, will be the ones primarily going into the field whenever there is a need to do a home visit. A registered dietitian is an interesting ad because what you'll notice is diet is so key to the success of our patient population. So the dietitian will be able to educate that patient either in the field or when they come into our clinic and say, what are your habits? How can we change them? If money's a factor, let's see what programs are in existence with community grocers. If variety is a problem, let's see if we can expand your horizon and involve farmers markets. And of course, you'll have the traditional front office staff.
Okay, I'm going to talk to you guys about our proposed payment model between Mercy and Buckeye. So one of the things that we've asked Buckeye to do is to provide us 6 months to allow the patients to transition from their existing providers over to our network. Because a lot of providers are going to drop from the network, we don't want the patients to be left without a provider or not knowing who their provider is or being confused. The demo allows us to get one payment from both Medicare and Medicaid and to submit one claim. So that's a key proponent for our hospital. Additionally, in order to improve the management of patients, we've requested that Buckeye work with Mercy to provide prior claims data so we can really analyze what type of patients will be coming into our system. One of the key components of the patient-centered medical home is that each patient will have one PCP and one care transitions coach and one dietitian. And that group will be a unit that the patient can navigate to throughout their care. Our payment structure is that Mercy is going to receive a risk-adjusted capitated payment for each dual eligible based on demographics, chronic diseases, and their general health profile. This is really important because the majority of dual eligibles have at least 2 chronic diseases. So we're talking diabetes, COPD, hypertension. Capitation rates are going to adjust semi-annually based on changes in their target population and then yearly based on economic indicators. At the conclusion of each plan year, Buckeye is going to split its shared savings with Mercy. And so this is really an incentive for our physicians to be able to, and our providers to be able to treat the patient in the best way at the lowest cost. One of the things that we've learned is that chronic care is the pattern with the dual eligibles, and there's been quite a bit of research as far as chronic care is concerned, and one of the most famous models is by Wagner. And his chronic care model really links the health system, the community, with the patient, and with a practice team. And that's really the way that you get the outcomes of decreased costs and improved care. So based on that, the targeting components that are available are to target specific patient groups, and we're going to organize our patients based on their patient-centered medical home, based on their chronic illnesses. Access to timely information, which we're going to do via CliniSync, Buckeye's notification system, and our EMR. Close interaction between care coordinators and primary care physicians. They're going to be in the same patient-centered medical home. They're going to be down the hall from one another. They're going to have access to each other. Services provided focused on interventions, on assessing care planning, educating, and coaching patients on self-management. And this is the key part that doesn't really happen right now. We really need to get the patients more involved with their own care, as Robert and Alethea both mentioned. So, show us the bottom line. So what we're going to do is model this after the California demo. They've had quite a bit of success. They've shown that if you're able to achieve the 5 prior models, then you can have inpatient utilization drop in 15% in year 1 and up to 20% in year 2. Our SNF utilization is going to drop because we're going to have the patients taken better care of before they get into the hospital and then with their management after they're discharged to prevent them from having to go to the SNF. Physician utilization is going to increase, obviously, because we're pushing pressure off of the hospital onto the primary care provider. And our pharmaceutical utilization is also going to go up because our patients are going to get more compliant with their medication management. We're going to implement 5 primary care medical homes in year 1, and we're going to estimate about 60% population utilization, which is about 5,900. And we're going to bring on 5 additional homes in year 2 at about 90% utilization for about 8,800. Year 2 capacity will equal for 100%, but it's very unlikely that we'll be able to get 100% participation, but we're going to try. Each primary care medical home will serve no more than 1,200. By law, they can't serve more than 1,500. So we're going to allow ourselves a 300-person buffer there in case the population increases. Our physician and EMR costs are irrelevant because we're going to have them regardless of our plan adoption. Buckeye's going to be covering all telemedicine, marketing, and incentive program expenses. That really helps Mercy sort of take a back seat as far as marketing is concerned. Novo Nordisk is going to fund all of our diabetes education material programs and training. And that's just something that they do because they produce most of the diabetes drugs. Inflation is applied at a rate of 3%, and fringes are estimated at 25%. So essentially, the cost of the program in year 1 is about $3.3 million, and that includes the capital expenses. And what we are proposing is that we integrate existing medical homes and bring them up to our plan. So we're not going to be building any new structures here. We're seeking out physicians in the community who already serve these patients. We just want to bring them into the Mercy system. So the average cost of an Ohio dual eligible patient in 2011 was about $40,000. Mercy St. Vincent, which is one of our 5 hospitals, total cost for dual eligibles was $230.9 million. That means we're assuming that 58% of all dual eligibles care happens in the St. Vincent's Hospital. It's highly unlikely, to be honest with you, because there are about 100 facilities there, and so right now the costs are astronomical as far as all that's concerned. The cost of the program is about $3.3 million. With effective care coordination model implementation, estimated savings are 25 to 34% of inpatient costs, and that's from year 1. So these cost savings are astronomical by combining all of these programs together to really navigate the patient. And so with that, just from our Mercy St. Vincent's Hospital, we can estimate about $57 million in cost savings in year 1, with our net cost reduction approximately $54 million.
You've heard about the dollars and cents, but Mercy and Catholic Health Partners is more than just about that. They're really about the patient. This is about Margaret Jacobs. Our model will ensure that Margaret gets the care she needs directed through the patient-centered medical home, regardless of where she receives that care. The PCMH is still going to be involved. We'll review orders to ensure that they're followed appropriately. She won't be sitting in the SNF getting her blood drawn and not getting her physical therapy because our care coach will be out there on some kind of a regular basis checking in with her. We're doing all this to ensure that the care that we provide is for the individual, not for the disease. And we thank you all for your time.
That internet webcam, what exactly you use that for?
The Xbox Connect will be funded by the community health plan. The patient will use that, and our wellness coach will be the primary person to engage and educate that patient how to use it. Chances are they'll be elderly, they may not be familiar with that technology. We can't count on a grandson that is using it all the time to educate them.
Although we think that with it being an Xbox Connect, the grandsons might show up at the
Yes,
house
maybe.
a little more often.
Grandma will be popular all of a sudden. So the person doing the education portion would be that wellness coach. Now, the reason why the health plan chose that, I don't know if they had an arrangement with the supplier, with Microsoft, but it was a way to get the Xbox has all of the internal components needed to get on the internet fast and reliably. So that may be the reason why they chose that device.
And the other thing too is many of these patients, as we mentioned, have disabilities. They lack funding to have access to transportation. And the majority of them have mental health problems. And so the big thing that we can do here is utilize psychiatric and mental health care via the telemedicine unit, via the Xbox Connects in their home. That way, if they do need to seek help from a mental health professional, they may not have to leave their home. They can just flip on the Connect and connect with their patient-centered medical home or connect with one of our psychiatric facilities.
If I got this right, you said that you're trying to still use the physicians and the nurses that the patients already had to bring them into the Buckeye program. So what if they don't want to go into the program? What do you do?
They have, there's probably some background that you all may not have been familiar with. This is a demonstration project going on between the state of Ohio and CMS, and they have contracted with 2 different plans. One is Buckeye and one is Aetna. So everyone who's dual eligible is going to enroll in one of those 2 plans. Mercy itself already has about 500 employed physicians, and they're on their way projected to go to 900. Now that's statewide, but we already have some in place in Toledo. Buckeye's already the Medicaid contractor in the Toledo area, which means that these patients are very familiar with Buckeye to start with. That's really part of the reason that we chose Buckeye over Aetna, because we thought that Buckeye had a better presence and was going to be able to bring more people into their program much faster than Aetna would be able to.
And Catholic Health Partners is slated to have about 50 patients in our medical homes within the next 5 years. So they're going and seeking these already established physician practices and trying to convert them over to the health plan. One, it's going to give them access to better payer contracts for their other plans. And so it really gives them the leverage of the EMR, which they may not be able to have in a small facility, and then the access to the many specialties and other surgical facilities of our health system.
I think I walked in on the latter end of this discussion, but you mentioned something about if a patient gets checked out and gets their data inputted into the EMR, other physicians at other facilities also have access to that medical record?
Yeah, it works in a couple of ways. If they're Mercy affiliated and it's in our EMR, they have access. Now, there's obviously there's other controls in place to prevent any physician from getting into a patient's medical record. They have to have some kind of a treatment relationship. But Ohio also has a health information exchange. So not just Mercy, but a lot of different providers are making their information available on that HIE, so that if my patient had seen you and you're non-Mercy, but you participate in the HIE, I can go in and look at the lab tests that you ran.
And that's a state-run program?
Yes. That is state. CliniSync.
And then Buckeye also gives us access to their claims data for any other Buckeye facilities that they have.
And if I could go on a tangent, I'm sorry, Dr. Ayadi. In real life, you may not be familiar with something called the Blue Button Initiative. This is something that's really big in the Veterans Affairs Department. You're going to start to see more and more about this. The move in the future is to empower the patients and have them have access to their information and have it downloadable to whomever they decide to provide care. So that statewide exchange, you're going to see more of that in the future, especially as the Affordable Care Act goes into place and more of these health exchanges come to exist. There's going to be a need for a network to coordinate that information. So you're going to see more and more of that. I'm sorry, Dr. Ayadi. Yes, ma'am.
I was just wondering why that woman didn't speak up and say, shouldn't I get physical therapy? And why are they still taking my book? You know, like 2 weeks.
I will tell you, because it's my grandmother-in-law. She didn't know any better. She had just suffered her 3rd stroke. Her speech was impaired. Her mental faculties were impaired. She doesn't live here in Houston, so we couldn't check on her in the ways that we would have wanted to be able to. And she just didn't know to tell them.
Family member around you could have said.
And many of the patients and their family members aren't proficient in the health field, and they don't feel right questioning the providers. And that's one of the biggest things that the Patient Centered Medical Home strives to address, is to really break down those barriers and have the two-way communication between the groups and engaging that family in the patient's care versus it being just the physician providing the care plan.
And that's why I think the choice of having a licensed social worker as that health coach is really key. That person's role, they're going to be knowledgeable about that region, that state's, that city's programs and offerings, and they're also going to have a modicum of knowledge of patient rights and patient flow. how should this patient progress and transition to the next level of care? Is it being done appropriately? I think having a licensed social worker is a win in that role of a coach. And the goal is to keep that coach married, so to speak, with that patient as much as possible, so that that patient presents in another facility, a skilled nursing facility, mental health, that same person, because we know this elderly population probably doesn't appreciate change very much. So if we can help them and assist them by keeping the same person as their point of contact, their liaison, so to speak, we know to go a long way towards caring for them first, and then of course keeping them engaged in our new continuum of care.
Yes.
Yeah. As you said that telemedicine for old age people, especially mentally and psychiatrically challenging, how would you motivate them or train them to get used to those telemedicine instruments, which is a critical factor?
Well, in addition to the care coach going out to help with that, if it is a patient who can't, for whatever reason, won't even participate, we can actually send a staff member out to help them through the process. So if they need to have a visit with, let's just say a specialist, but they didn't need to go in, so it was a follow-up, routine follow-up, one of our staff members could go out and help them with the telemedicine process from their home.
And the transportable exam station also has leads to connect to monitoring devices. So if the physician extender or the nurse needs to go out and you plug up the blood pressure cuff and the heart monitors to the transportable exam station, it's fed directly into the EMR from the patient.
Yes. All right. Very good.
Thank you all very much. And I think all of us, I think I speak for all of us when we encourage you, the case competitions are really interesting. This particular one has teams of 3.
Yes.
There's a team of 4 competition that we competed in with PERAC at UT Health Science Center, which we won, by the way. Sorry. But it really is, it does give you the opportunity to look at a real life situation and figure out what it is that you would do and apply everything that you're learning in all the classes, and sort of think outside the box and how would we do this and what would we do. And for example, at this particular case competition we were just at, there were people there from Mercy. And so they were listening to see what some of those ideas were, because they were working on the very same project that the case competition was working on.
The winning team was actually flown to Ohio to present to the executive board of Mercy and Catholic Partners.
There's as an additional incentive, there is scholarship money attached to how you finish. And our team made it to the semifinals. They were up against Cornell and Michigan and Iowa. They represented us extremely well. There are other case competitions that we're looking at going to. The University of Alabama Birmingham has one. We were fortunate this year that the NAHSE competition was in Houston. The year before it was in Las Vegas. It moves around. But you also get to network with the other teams. It's not you go in and present and leave. You're basically there for 3 days. They have a lot of networking and social functions. And as you can see, we have the cream of our crop. They have the same. And so you're getting an opportunity to meet and network with and spend time with top students. Robert was on the team last year, and several of the people that he met last year, he saw again this year. And so there are a lot of advantages to doing this. And so I've been their faculty sponsor for 3 years now. I'm giving that up this year. But they do it all. I mean, they found all of this. They did all the research. It's pretty intense 3 weeks.
Yes, ma'am.
But it's worth it. It really is. You get a lot of benefit.
Do you all have any of those kinds of questions about the case competition or any of that, rather than just the presentation itself.
Can you talk a little bit more about NAHSE?
Sure.
And I'll try to explain to my other class. Like, do they have a local chapter in Houston and meetings in Houston or something like that?
So-
Somebody asked, do we have a student chapter of NAHSE?
So what is NAHSE? NAHSE is a national organization dedicated to promoting young minority leaders in healthcare emerge. So they reach out no matter where you are in your scope of your career, and they try to engage you. The annual conference offers things besides the case competition, which is sort of the leading event. There are workshops. What I mentioned to you about Blue Button, that was available in that workshop. They invite subject matter experts across the country to come to this conference and speak about relevant topics today. Learning and going to these conferences gives you more day one skills, more day one talking points to help you get that first job, so that you can entertain a viable conversation with some of these executives you're rubbing elbows with at ACHE and MGMA. This gives you valid talking points. So that's what the organization is about. It's about empowering, it's about diversity at the end of the day. So when I look at this room, I see a lot of diversity, and I really encourage all of you to take part in this organization. And Dr. Ayati mentioned, asked if there was a Houston chapter. There is. It's newly started. It's been about a year in the making now. I would encourage you to go to their events. There's a social, if you kind of want to just get a feel for the people or organization without sitting in any formal meeting. Every third Wednesday, there's a meeting. It may be not this month because of the national event. They meet at a place called Mallorca. It's a little tapas place in Midtown. So it's right on West Gray. So I would encourage y'all to do that. And was there a third item you had mentioned? There's not a school affiliated NAHSE group to my knowledge yet. But if someone wanted to get one started, I'm sure we could find a support from the Houston chapter to make that happen.
Robert, if you'll send me the information about their monthly networking meeting, then I'll send it out to all the students.
Yes, sir.
Any others? Very good.
I have one question before you let them go.
Okay.
The person who just came to eat and left